Good afternoon, everyone, and welcome to the webinar, Best Practices and Systems of Support, Addressing Substance Abuse Among Our National Guard and Reserve, sponsored by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center. My name is Alexandra Mead, and I will serve as your moderator for this afternoon. I'm a project manager with the National Council for Mental Wellbeing. Before we begin, we'd like to draw your attention to some important webinar logistics. There are two audio options for today's webinar, joining by phone or by computer audio. If you're using your telephone, please make sure to enter your audio PIN number into your phone. You may send us questions at any time during the webinar today by submitting them through the Q&A option located in the Zoom navigation bar. Towards the end of our time together today, we'll answer as many of your questions as time allows. Today's webinar is being recorded, and a recorded version of the entire webinar, as well as a PDF of the presentation slides, will be available on the webinar archives page of the National Council website within 48 hours of today's broadcast. Following today's webinar, we invite you to please complete a short survey, which will automatically open in a new browser window following the session. And now, if you're ready, Dr. Lattimore, I'll pass it over to you.
Thank you very much, Alexandra, and good afternoon. My name is Barbara Lattimore, and I am a Senior Project Associate with SAMHSA's Service Member Veterans and Their Families Technical Assistance Center Policy Research Associates. We're very happy to have you all with us today. Next slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration, SAMHSA, or the U.S. Department of Health and Human Services. Since 2008, SAMHSA has partnered with states and territories to strengthen behavioral health systems serving service members, veterans, and their families, or SMVF, providing technical assistance through its SMVF TA Center. SAMHSA leads efforts to ensure substance use and mental health issues among all Americans, including SMVF, are well understood. Some of the goals of the SMVF TA Center are strengthening ongoing collaboration among military and civilian stakeholders, providing a centralized mechanism for cities, states, and territories to learn, connect, and share, increasing awareness of and access to resources and programs that strengthen behavioral health care systems for service members, veterans, and their families, supporting coordinated responses to the behavioral health needs of SMVF, encouraging cities, states, and territories to implement promising, best, and evidence-based practices. Next slide. The SMVF TA Center provides training and technical assistance through activities such as policy academies, implementation academies, crisis intercept mapping, webinars, learning communities, technical assistance call series, on-site and virtual expert consultation, as well as resource dissemination. Next slide, please. Some objectives of this webinar are to understand the National Guard Bureau's policy and programming for service members within SUD, explore some of the unique challenges faced by individuals with SUDs in the National Guard and Reserve communities, increase knowledge of innovative strategies to engage individuals with SUDs in the SMVF community more effectively, with a special emphasis on those in active duty. Next slide, please. Other objectives: explore the data along with the efficacy of current and emerging treatment modalities recommended for individuals with co-occurring SUD and mental health diagnosis. Explore strategies to increase identification of risk factors and warning signs displayed by service members, and leverage protective factors and resources in the community to help them. Examine how to raise awareness and increase understanding in the military and civilian communities to reduce stigma and increase help-seeking behaviors. Next slide, please. I have the distinct pleasure to introduce our three esteemed speakers today. I will introduce all speakers at the same time, and that way we would give more time for their presentations. I will start with Staff Sergeant Virginia M. White. Staff Sergeant White is the drug testing coordinator, non-commissioned officer in charge at the National Guard Bureau's Joint Staff Warrior Resilience Fitness Division Substance Abuse Program in Arlington, Virginia. As the drug testing coordination NCO, she manages, trains, and oversees 79 drug testing coordinators in all 54 states, territories, as well as the District of Columbia. She serves as the national level subject matter expert relating to drug deterrence and policy and is responsible for drug testing efforts nationwide. Additionally, she acts as a liaison between the Forensic Toxicology Drug Testing Laboratory and the Army Resilience Directorate. Staff Sergeant White enlisted in the Washington State Army National Guard in August 2004. She has been a member of the Army National Guard in North Carolina, Georgia, and Hawaii. Staff Sergeant White received her BA in psychology in 2011 and her MA in clinical mental health counseling with South University in Savannah, Georgia. She is pursuing her PhD in clinical psychology. Please help me welcome Staff Sergeant Virginia White. Our next speaker today is Calandra Q. Ferguson. Calandra Ferguson serves as the Alcohol, Drug, and Control Officer, as well as the Risk Resiliency Coordinator for the Georgia Army National Guard's Substance Abuse Program. With the guidance of Ms. Ferguson, the Substance Abuse Program was developed in 2013. She has served as the program manager since the program's inception. This three-tier program focuses on unit risk inventories, or URI, to identify high-risk behaviors, providing education on the effects of drugs and alcohol on the body, and connecting service members to appropriate community resources to treat substance abuse issues. Ms. Ferguson's duties also include providing command level consultations and briefings to senior leaders and others on current drug trends of soldiers within the state, as well as high-risk behaviors within their unit. She also aids commanders in developing mediation plans to reduce high-risk behaviors. Calandra is a military veteran with 24 years of service. During her military career, she deployed in support of Operation Enduring Freedom and Operation Iraqi Freedom. While in the military, she served in various positions, including senior interrogator, human intelligence collector, platoon sergeant, recruiter, and senior human resources officer. Lastly, Ms. Ferguson is a graduate of the University of Phoenix with an associate degree in healthcare administration and a bachelor's degree in psychology, as well as a certification in human resources. Please join me in welcoming Calandra Q. Ferguson. Our next presenter is Captain Katrina Latanya Tripp Dinkins, USA retired, LPC, MAC, NCC. Ms. Tripp Dinkins is a licensed professional counselor, a master addiction counselor, and a nationally certified counselor. She has experience in supervising and providing training to counselors within the field, as well as extensive experience in working with military members with substance use and other disorders. She is a retired Army captain. She earned her bachelor's in psychology and master's in mental health counseling from the Fort Valley State University. She is currently pursuing a doctorate in integrated behavioral health from Arizona State University. She has over 20 years of experience working with adults, children, veterans, families, and couples. She also has extensive experience working with individuals who struggle with depression, anxiety, PTSD, adjustment disorders, and mood disorders. LaTanya's philosophy is that everyone has an inherent and unique set of qualities. Once individuals have gained a level of self-awareness, self-confidence, and the ability to utilize learned coping skills, they will have the tools for lifelong success. Please join me in welcoming Captain Katrina LaTanya Tripp Dinkins, retired United States Army. Thank you very much, presenters.
Good morning, everyone. Thank you, Dr. Lattimore, for the kind introduction. As Dr. Lattimore said, my name is Staff Sergeant Virginia White, and I work for the National Guard Bureau, the Warrior Resilience Fitness Division Substance Abuse Program. I am the drug testing coordinator in COIC, and as she said, I do manage and I provide oversight on the 54 states, territories, and District of Columbia, the drug deterrence programs. Next slide, please. Okay, so I just want to take a moment to talk about the National Guard Substance Abuse Program. So what we do, as I stated before, we support the prevention and drug deterrence efforts within all the 54. And the intent of the program is to really strengthen the overall fitness and effectiveness of our soldiers. The number one thing that we're looking for in the Army is to have a force that's ready. And when soldiers are experiencing issues with substance use, then they're not ready. So our program enhances the combat readiness of them through drug and alcohol prevention, testing, and education. Next slide. Okay, so part of what I do up here at the national level is we work with policy, and we oversight the programs within the 54. So our main regulation that we utilize is the AR 685. So per the AR 685, soldiers who are identified as illicit substance users are to be referred by their commander for possible enrollment in state certified, community-based alcohol and other drug counseling and rehabilitation service, within 45 days of a verified positive drug test or through self-identification. And then what that means is monthly we drug test our soldiers. It's a method of deterrence, and it's regulated to drug test them at least 10% a month. And then when soldiers are identified through a positive drug test, the commander then would need to counsel the soldier and refer them for possible enrollment and to get a substance use disorder assessment. Per the regulation, commanders will also refer all soldiers who are identified by alcohol testing, driving under the influence, driving while intoxicated, investigation apprehension, underage drinking, and reportable incident involving the use of alcohol for a substance use disorder within 5 days of the incident. Next slide. Also, within that regulation, for soldiers to use, other than being identified by a drug positive, we have what we call the limited use policy. So the objectives of this policy is to really facilitate early identification and care of soldiers with substance use disorders and maximize substance use disorder treatment. Now, what this policy is to encourage soldiers to proactively seek help for substance abuse related issues before they're identified through apprehension or through a positive test. There are some stipulations with this policy that would prohibit a soldier from using it. So soldiers can't have knowledge of a pending drug test prior to coming forward for help. And this means when they show up to drill, if they know they're going to conduct a UA, which is a drug test, they cannot come forward and want to use their limited use policy. The limited use policy becomes effective immediately. So once a soldier goes to their commander and they want to use it, it is automatic. The limited use policy is not intended to protect a soldier who's attempting to avoid disciplinary or adverse admin action. Something I want to point out with this limited use policy too, because we get questions from the field a lot about this. If a soldier overdoses or a soldier has alcohol poisoning and is brought into the ER for emergency care, what we consider that is a cry for help. So they would be protected under limited use policy. They cannot be brought in by the authorities or through apprehension or not subsequent to a traffic accident or criminal offense. Next slide. Another way that the National Guard Bureau and really the big Army is trying to encourage soldiers to come forward for problems or issues with substance use is they've implemented in FY19, fiscal year 19, the Army Directive 2019-12. And this is to reduce the stigma attached with those to seek help for alcohol-related concerns and to increase the likelihood of soldiers coming forward for help. This policy encouraged soldiers to voluntarily seek alcohol-related behavioral health care. They may proactively re-enter behavioral health care as needed without being mandated to enroll in substance abuse treatment. To qualify, soldiers must not meet the mandatory enrollment criteria as outlined in AR 600-85. What this means is if a soldier just receives a DUI and they go to their command and they say, hey, I would like to use my voluntary alcohol policy, the DUI would disqualify them from using it, and now it would meet the regulatory requirement for a mandatory enrollment. Using the voluntary policy prevents the enrollment from reflecting on the soldier's official drug and alcohol record. It does not require them to participate in treatment and follow mandatory enrolled substance abuse treatment policies as described in the regulation, excuse me. The good thing about this is alcohol is the most #1 abuse substance, but we don't test for it. So the regulation does lack guidance on a regulated test or a monthly testing for this. But as we all know that alcohol is readily available. So this is a perfect opportunity and policy to reduce the stigma for soldiers to come forward and seek help. Next slide. Okay. Additionally, at the Guard Bureau, so what we do that's a little bit different than what active duty has. So the National Guard utilizes a national contract for their risk reduction coordinators and their prevention coordinators. So within that contract, the RRCs and the PCs are to have a working knowledge of community outreach and prevention initiatives and programs. What this means for us is we have 54 ways to do things, and there's 54 different individuals, RRCs, and we have 77 prevention coordinators. It is the methods that we use and the community resources that are available to our soldiers, they vary greatly. So it's up to the RRCs and the PCs to develop those working relationships with the community. So once they identify the approved substance abuse assessment and community referral services, excuse me, that's what they utilize to assisting with the referral for soldiers. Next slide. Okay, psychological health. So the National Guard Psychological Health Program provides service members and their families with resources to master psychological health challenges and maintain operational readiness. High quality behavioral health services for individuals are provided, with confidentiality maintained while professional treatments are coordinated. Educational resources to maintain and improve personal resiliency are also provided. Ms. Calandra Ferguson and Ms. Tripp Dinkins are going to discuss more about the national contract and the psychological health aspects of this program. Next slide. So a substance use disorder assessment. So this is what the soldiers are regulated once they're identified as illicit substance users. So I just wanted to highlight a few of the things that kind of stem from those assessments. So it is a regulatory requirement, as you can see. Part of what the regulation states is that the soldier must be referred using the DA form 8003. Now it is a Department of the Army form, and the soldiers are to take this form with them while they get their assessment. I'm going to discuss on the next slide some of the challenges that we face with that form. The substance use disorder assessment determines the presence of a substance use disorder diagnosis. This is really critical for commanders to have this, to get a baseline of where their soldiers are at, if they have a problem, and then the resources additionally that the RRC and psychological health should be providing. What is unique about us in the National Guard is our soldiers are citizen soldiers. So majority of our force are drilling soldiers 2 days out of the month and then 2 weeks out of the year. So unless the soldier is on orders of 30 days or more, they do not qualify for TRICARE Prime. The bulk of our soldiers who are illicit positive and need assistance are between the ages of 18 and 25. And as you can imagine, they are either underinsured or uninsured. So the costs are the responsibility of the soldiers, and sometimes that is a challenge in itself. Some states are able to leverage behavioral health teams to administer assessments, depending on the staffing, resources, and qualifications. They're on different statuses, and sometimes their scope of duty does not include doing assessments. Next slide. Okay, so I really wanted to share with you all that during fiscal year 18, we conducted a survey of over 1,000 soldiers who had not completed their mandatory assessments. And this was an effort for our contract staff to kind of get a good grasp on things, and us at the national level where the challenges lie with our soldiers. So there were many reasons, but I did want to highlight some of these because, as I talked about before, soldiers are citizen soldiers. They're geographically dispersed throughout their states. Some of them have very limited access to care. That was a reason. Another thing that the soldiers disclosed was the financial burden. I talked about the age range of our illicit positives. The cost of assessment ranges probably around 70 to about 400, even more depending. And then if you can imagine the cost associated if treatment is needed. They're uninsured, underinsured, difficulty contacting soldiers to provide resources. Excuse me. Ms. Calandra Ferguson will kind of get into that during her presentation about some of the challenges that she faces with that. And I discussed on the previous slide, the 8003. The provider has not supplied necessary documentation of the assessment. A lot of times they're really reluctant to use any forms outside of their own practice. So it is difficult for the soldier to have, bring back that documentation to prove that they have conducted their assessment. And lastly, mandatory discharge. So the final separation authority within the states is the TAG. Sometimes the soldier believes that, if I test positive, I'm going to get kicked out anyway. So why do I want to get an assessment? And those are unique challenges nationwide, but every state experiences them. Next slide. Okay, so additional considerations. So I wanted to talk about some additional considerations with us. I talked before that we are geographically dispersed. So when you have large states like Texas versus small states like Hawaii, our soldiers are so far away and can live in very remote areas. So the Guard relies on a variety of solutions for care, just based off what the soldier qualifies for, their financial means. Assessments are very important because when a soldier is positive or comes forward for limited use, it's going to allow the commander to assess the level of care the soldier needs, the resources they need, and the potential for rehabilitation and retention in the National Guard. Because at the end of the day, our service members are citizen soldiers, and it's critically important in identifying challenges faced and adequate resources. So they can not only be great assets to, the National Guard, but to the communities in which they live. Okay, well, pending any questions, I'm going to go ahead and pass it on to Ms. Calandra Ferguson. She is the risk reduction coordinator, as you heard in her bio, for the state of Georgia.
Thank you, Sergeant White. Hello, everyone. I'm Calandra Ferguson, like they said, and I'm the Dice Tech contractor. And my role is the risk reduction coordinator for the Georgia Army National Guard. Next slide, please. The Georgia Army National Guard Soldiers Support. Our substance abuse program is co-located with the substance abuse prevention coordinators, the suicide prevention coordinator, the drug testing coordinators, the state resiliency officer, who's also our master resilience trainer, the psychological health coordinators, and behavioral health coordinators. We work alongside all these programs, and this allows for us to have a more integrated care of our soldiers. We're all fully aware of each other's programs and their standard operating procedures and the roles that we each play when we continue to work toward the soldiers' overall wellness. Our offices are away from the flagpole. We're away from the headquarters building with limited visibility. That was done strategically because we want all the soldiers to feel comfortable when they come to meet us. We're all HIPAA certified and fully understand the need to know and the importance of anonymity for those soldiers who come into the office, whether it's to meet with the behavioral health coordinators or if it's a substance abuse issue. We also have weekly crisis intervention teams that meets to staff behavioral health and substance abuse cases. These teams are consisted of myself, the suicide prevention coordinator, the psychological health coordinators, behavioral health case managers, chaplains, and unit representatives. These teams encourage the continuity of care for all of our soldiers. Next slide, please. Substance abuse disorder assessments, regulatory requirements. As Staff Sergeant White explained about the SET assessments, when we receive the illicit list from the drug testing coordinators about the soldiers that have tested positive, we normally allow 60 days before we reach out to the commander. And there are times that the commanders may not have had an opportunity to counsel the soldiers. For example, if the soldier tests positive in May and the results come back after the June drill, then the commanders won't have an opportunity to meet with them until July. So it takes a while for the soldiers and the commanders to have the counseling. But what happens is after it's been 60 days, my team will reach out to the commanders and we'll ask them if they had an opportunity to do a counseling with the soldiers. If they say they have, then we get permission from them to reach out to the soldiers. And we reach out to them and we offer them the services that we have. If they decline, then we ask them to send us an email or something in writing that says, I choose not to enroll into the substance abuse program. But if the soldier says that they do want to enroll and they have been counseled, then we just get the ball rolling and we get their enrollment started. So we talked about the forms. We use the DA 8003 for the enrollment for the soldiers, as well as DA 4465 and 4466, which is the patient intake form and the patient progress report. What we do to help the ball get rolling is we will do the administrative portion of it and we'll forward it to the commanders and the soldiers as well as the providers, so that way nothing is lost in transit. In addition to the DA form 2446, so that they can release the information that we need. Now, there are a lot of providers that are hesitant to fill out the forms, but some of them, when it comes to the soldiers' information, will do a narrative instead of the forms. I'm sorry. And but a lot of them will fill it out, and that's partly in part to the STAR program. We're glad that the STAR program is available and they are given information on how to complete the forms. When we talk about soldier status, there are different statuses of soldiers in the National Guard, and that determines the type of insurance that they have, if they're insured or if they're not. The traditional guardsman, that's the M-Day soldier. That's what they would traditionally say 1 week in a month, 2 weeks out of the year, but they actually devote more time than that. But they are also a dual status. They can be a technician, so they can have insurance that way. But the traditional Guard soldiers, they're encouraged to get the TRICARE Reserve Select, so that way they can have insurance, and that can come straight out of their drill check. But they can also use their personal insurance, like we said. They can use their Kaiser or their Blue Cross Blue Shield. AGR soldiers. The AGR soldiers are the active duty type soldiers, so they can use TRICARE Select for their coverage. But we also have soldiers that are on orders 30 days or more, and these are the ADOS or the 502F. You know, these are people that have been on orders, maybe whether it's the border control or COVID mission, that they've been on orders for more than 30 days. So therefore, they are covered by TRICARE. Next slide, please. So some of the challenges that we face quite a few challenges. And one of the main is the inability to contact soldiers. Soldiers move around, they move from state to state, they may change their phone numbers, and they may not have the opportunity to update that information when they come to drill. So we'll call them, we'll text them, email them, and we're not above using social media. I mean, we'll DM them if we have to, because sometimes people are more active on social media, you know, than they are with their regular phones. We'll contact the units to see if they have any updated information. but because we're also co-located with the psychological health coordinators and behavioral health case managers, we can go to them and we can see what information they have too. So we're all working so that we can have the best contact information for that soldier so that we can reach out to them and offer them the program. Another challenge is the financial burdens of the uninsured and the underinsured. So some of the best practices, partnering with the community service and establishing a list of providers that have sliding scale payments. If you don't have insurance, we do try and find one of the many community service boards or partners in the community, which will offer services on a sliding scale. And they can use their drill income as the basis for the sliding scale. For many of our soldiers, though, this may be the only source of income that they have. So they can use their drill checks. We also use private organizations like Centerstone Counseling, where soldiers can get up to 12 free sessions. We use Military One Source, Give an Hour, and some of the other partners that we have in the community. As we mentioned before, we also encourage the soldiers to select to have that TRICARE Reserve Select, where the monthly premiums can be deducted from their drill check, so that way they'll have healthcare coverage at a minimal cost. Another challenge is geographical disbursement of soldiers throughout the state. You know, everyone knows Georgia, they know Atlanta, which is a large area, a large city, but we also have many small communities. So what do? We continually update the National Services database of providers. That database has their hours of operations, the type of insurance that they have, if they're doing telehealth, if they can see family members and children, their adolescents, in addition to seeing the soldiers. And some of them too, you know, whether it's a veteran with a DD-214 or whether it's a veteran with an NGB-22, you know, they will see them as well. So what we have too, so those areas that have very limited access to providers, there's telehealth available. And COVID was a horrible thing, but it did increase the number of telehealth providers that are out there. And we were also able to use the telehealth for our internal resources with behavioral health and chaplains, as well as the external for the providers that are out in the area. So those are some of the challenges that we face. Definitely not all of them, but those are some of the challenges that we face. And these are some of the best practices that we have. Next slide, please. Right, this is my contact information. So barring any other questions, I turn it over to Ms. LaTanya Trent-Dinkins.
LaTanya, I think you may be muted. Okay.
I apologize.
Thank you, no problem. Much better
Hello,
now.
everyone. I'm LaTanya. I mean, don't you just love this COVID world and virtual world that we live in? So again, I'm LaTanya Trent-Dinkins. I'm the psychological health coordinator for the Georgia Army National Guard. And thank you, Staff Sergeant White, and thank you, Ms. Ferguson, for going through those policies and procedures and also drilling down into what we do here in Georgia. And it runs the gamut, as Staff Sergeant White pointed out, that there are 54 states and territories, and every state looks different. And Georgia is no different from that. We do a lot of things differently here in Georgia, and we try to be creative. So what I'm going to discuss are some of the case presentations that we see. Before I get started with that, I want to put this disclaimer out. I know a lot of clinicians are on the call, but these service members' information and identity has been protected. The information has been changed. However, the context of this information is very real. Some of the services that were provided were very real. And also, as a contracted behavioral health provider, I know we mentioned that we can leverage the support of behavioral health providers. However, contracted behavioral health providers here in Georgia are not able to conduct substance use disorders assessments. However, we do partner with community partners to provide those assessments. In addition to that, if they are active guard and reserves, and we're going to talk more about that as well, or they're on orders longer than 30 days, then we can access those services through our local MTFs or military treatment facilities. But however, when a service member is referred to us, we go ahead and conduct a series of assessments. And those assessments may include a PCL-5, a PHQ-9, PHQ-2, anxiety, the GAD-7, the Columbia Suicide Rating Scale. It runs the gamut. And we do this through the Behavioral Health Data Portal. So anyone that touches that service member across the state or another state, they can go into that system and see what those assessments produced and where that service member risk factors lie when they were assessed, no matter how long ago that assessment took place. Next slide. So as we pointed out, we talked about traditional guards members, we talked about AGR status and technician status, and now we're going to really drive home what all that means and what that actually looks like when you are working with a particular service member. I know a lot of these cases that I'm presenting today are focused on alcohol use disorder and some of the co-occurring disorders, particularly PTSD. I just want to put it out there that we have been in COVID for 2 years, and our service members are typically drilling 1 week in a month, 3 weeks now during the summer. So you don't see a lot of the issues that they may present with. However, when you're on orders for 2 years, now we're going to start to see some of these behaviors and some of these substance use disorders that we didn't see or we cannot see on a drill weekend. And with that being said, we're going to start with Specialist Doe. Specialist Doe is a traditional guards member, meaning they drill 1 week in a month. However, they're also a technician. So they wear the uniform during the week, but they are a civilian soldier. Their diagnosis is alcohol use disorder, severe, and PTSD by report. And this was done when they were admitted into a hospital. That assessment was completed. The referral was through a company commander. And a little bit about Specialist Doe, female, Caucasian, single mother of 5 from East Georgia. Again, guards members are dispersed across the state. And so this service member has been a part of the National Guard for less than 4 years and no deployment history. So that goes to tell you that there is some history there, some trauma history that we had no clue about when they entered into the military. We didn't know about the substance use because that was longstanding as well. And this particular service member joined on a dare as reported by her leadership. And I put that in there because a lot of times when we're doing assessments, I want to know, I'm prior service, I'm a retiree. So I want to know, why did the individual that I'm assessing, why did they join the military? And so it was funny to me that this service member said that they joined on a dare. But I thought back about 5 kids, single mother, living with a family member, and they joined on a dare. And they're doing quite well actually with the unit. They were able to secure a technician position, but when they went away to a stressful environment, they became so stressed that they started using alcohol again, or at least we thought that that was the beginning. However, that was the catalyst that brought this particular soldier to our attention. And so once we got contacted because of the fear that this service member would be suicidal. And unfortunately, a lot of times the cream rises to the top. And if they become suicidal, then they're calling behavioral health. With alcohol use, keep in mind, the culture has been for so long that when you go to dinners and things like that, there's going to be alcohol. And we kind of negate the fact that alcohol use disorder is in existence and that service members become addicted at an early age to alcohol. And so this particular soldier was away at school and started drinking excessively after being told several times. They were assessed by a sub-C, which is substance use disorder counselor. They were assessed and recommended for inpatient. But this particular service member was also out of state. And we had to get them back, do a follow-up assessment, which was the BDHDP portal, and get that service member connected to services. Once we got them to a community provider, we noticed that that wasn't effective enough. The provider was good provider. However, the treatment that this service member required was a little more intensive than once a week, as we later found out. And so we ended up enrolling her in a 45-day residential treatment facility. Keep in mind, going back to traditional Guards member, she does not have TRICARE insurance. So her insurance is private, and she used her insurance and she covered half the cost of that treatment. So now she's in treatment. The treatment services that were provided was EMDR. That started to bring out a lot of the trauma history. Once she started that treatment, she panicked. She checked herself out of this treatment facility, ran, and commenced to doing drugs. However, safety, this service member was returned back to the facility, and she will be graduating soon. Her insurance, again, is private, and this service member supports not only included the community providers, the residential treatment facility, but her leadership. Her leadership got involved. So on three-way calls, three-way text messages, emails, we continue to communicate to make sure that we wrap services around this service member. And I did not say this before I started this part of the presentation, is keep in mind as we go through these cases that our philosophy is always no soldier left behind. And so no matter what, no matter how chaotic it gets or how burnt out we get, we need to practice some self-care. However, we also need to be mindful that no service member is left behind, even when we have to make the tough decisions at the end. Next slide, please. Okay, Staff Sergeant Snuffy, alcohol use disorder, active guard and reserve, AGR soldier, full-time service member. So alcohol use disorder, co-occurring PTSD. Referral was company commander. And a number of these, you're going to see that they were referred by the leadership. This service member had several failed attempts at substance use. 36-year-old Caucasian male, married with one child, 18 years of service, 2 deployments as an administrative support, 15 years of active duty time, AGR, and the service member had 3 DUIs. As you can remember, go back to those policies and procedures that we try to do everything. Our goal is to rehabilitate, but there is also disciplinary action associated with that too. After 3 DUIs, he's had tremendous leadership support, collaboration between the Georgia Guard and military treatment facilities. And I say this because he's an active guard and reserves member, so he can receive his treatment at any military treatment facility. So when he decided to get treatment, they were able to enroll him in active duty inpatient treatment in another state. That military treatment facility coordinated with us because his leadership is Guards members. So although they're housed on an active military base, they're still Guards members, and we're going to take care of our Guardsmen. Our Guard men and women, they belong to us, so we're going to take care of them. So we were all able to work together with this particular service member. However, I put in here, I just wanted to make it clear that the service member and their leadership started to report burnout with keeping him safe. Because keep in mind, we had 3 DUIs, we have suicide attempts, we've had a history of suicidal ideations. So they're trying to keep an eye on him, keeping a battle buddy with him 24/7 at times. And that was just impossible and unrealistic. And so they expressed to me that they were exhausted from trying to provide the level of care for this service member as they should. Again, no soldier left behind, but leadership and providers get exhausted as well. His treatment history includes individual therapy, military treatment facility, 2 30-day back-to-back residential treatment stays, IOP, and AA. No history of treatment prior to the referral following initial DUI 7 years ago. He has TRICARE Prime. He's able to access more services than your traditional Guards member. Next slide. All right, Sergeant Snoopy. 502F orders, COVID mission. This service member went from being a once a month, twice a week, two weeks out of the year service member to an active duty guards member during the COVID mission. He's been on active duty for almost 2 years now. No one noticed that he's had any other issues until he started to present at some of the work sites intoxicated. He was referred by the task force commander, and that task force commander is over everyone who are on the COVID orders. And so he's a 32-year-old African-American single male who resides in South Georgia. And he has over 10 years of experience, 1 deployment as an engineer, has no prior active duty service though. So he's only been in the Guard for the last 10 years. However, he's had that deployment, never received any treatment outside of the Guard, never presented and said, hey, I have an issue. It was only when he said, I'm feeling suicidal, that he was referred for treatment to the PHP program or the psychological health program. And so while on active duty, he reported that he was feeling suicidal. He contacted us, and this is how the community providers come into play. So this service member was stationed way down in South Georgia, rural area, but we were able to work with a military, a community residential treatment facility in that area, partner with them because we knew that we would have troops on the ground in that area. And just in case we needed some additional support, they were ready. And so we were able to get him to that provider, do an assessment, and get him in inpatient substance abuse treatment, detox, and PHP. Unfortunately, as a team, we saw that team included that residential treatment facility, the PHP program, so service members' leadership, in addition to that service member's mother, who was very invested in his treatment and care. We made a decision as a team, and the service member, we made a decision as a team that this was not the appropriate setting for him. But we didn't stop there. We were able to get some supports from a military provider over a number of, not a military provider, but a community provider that managed a number of residential treatment facilities to get him moved to a treatment facility. He's been on COVID orders, so he is able to access services through the local military treatment facility that was on an active military base. So they were able to work with us to get him approved through TRICARE, because right now he's on orders. He has TRICARE's insurance. So they were able to write the order to get him services, and we were able to get him moved into that residential treatment facility. And now he is still there, and we will be looking for his speedy recovery, and he's doing great. His insurance, again, is TRICARE. But however, when he comes off orders, his insurance will expire within 6 months. So he will continue to receive care for 6 months after he's discharged from active duty orders. Next slide. Okay, Sergeant Loki, 502F orders again. And this one was we really had to be creative with this particular service member. Alcohol use disorder, PTSD. This is one of those that we also looked at line of duty investigations. He's had several deployments and he was diagnosed with PTSD while on a deployment. So that warrants an LOD, which is a line of duty investigation. And so he resides in South Georgia, over 15 years of service, 3 deployments as a medic. And he was referred to treatment by his leadership, in addition to the military treatment facility that he was being serviced down in South Georgia. He's had multiple failed attempts at treatment. We were able to work with the residential treatment facilities down in his home area to just keep him so we can keep him safe until we can get him some additional supports. So in that process, we were able to send him for a medical evaluation. Well, first a Chapter 3 physical, and I'm going to talk about that a little bit more on the next slide. But then he was approved for the medical evaluation board, and he's currently in the medical evaluation board process. And he was also referred to Soldier Readiness Unit, or SRU unit, which is our old warrior transitional unit. and no treatment prior to being placed on orders, and he still have TRICARE Prime. And it just goes to show, again, no soldier left behind. We've been working with this particular soldier for over the course of the last almost a year now, and things have kind of calmed down. He's getting the treatment, he's participating, and each of these soldiers, I may add, although they have some failed attempts at treatment, they continue to participate in treatment at their level, if I must say, but they're participating. However, there are times where things just don't work out and the service member becomes a liability to the organization. And unfortunately, we have to have some tough conversations and make some hard decisions. Next slide, please. And this brings me to separation actions. And when I think about this separation action, I think about one of my own soldiers when I was a young platoon leader, and we had to cancel the soldier because he had 2 positive tests for THC. And so the second time we were doing the counseling, I pulled him to the side, like, "What's up, man? Why? Come on, what? Can we get you some help? We referred you. We're trying to support you. And what else can be done?" And he said, "I just want to know, how am I going to be discharged?" I said, "Oh, okay, you sure you don't want to know what we could do, what supports are out there, additional supports?" He's like, "No, just tell me, am I getting an honorable? Am I getting a administrative discharge?" So when I came back with the final answer, he was like, "Okay, cool, I can handle that." And he walked off. And that made me think that we just need to educate leaders and commanders and the service members on the types of separation actions that are available to them. Because some service members, they know that it may not be the right environment for them. They just want to know that how is this going to affect them in the long run. And so I just pointed out 3 of these chapter or separation actions that we see quite common. In my realm as behavior health, we see a lot of chapter 3. So we're going to make a referral or communicate with the command leadership on what would be the best possible action for behavior health evaluation so that soldier could chapter out through a chapter 3. And but chapter 9, unsatisfactory performance. This is your catch-all separation clause. This is a more administrative centric. For leaderships, they will have to provide unset counseling. So they'll go through the process of their record keeping. How do they keep good records? And we're at a crossroads, and we have to make a decision that this person can no longer continue to serve. However, VA and additional services are not given with an other than honorable discharge. And this option, and we try to save this one as the worst case scenario for the service members. Then there's a chapter 10, substance use rehabilitation failure. This is strongly recommended when we're dealing with service members that have failed out of treatment several times. And so this clause is specific to his rehab, inpatient failure. With the clause, he will get full physical evaluation. So with this chapter, that particular service member will receive all benefits as if it was an honorable or general discharge. And then, as I stated, the chapter 3 physical is primarily reserved for behavior health discharges. And these regulations can be found at AR 40-501 and AR 135-178. Again, if you were keeping up, no soldier left behind. We have the regulations, we have the policies and procedures in place, but as we care and as we take care of the soldier, we first want to ask them, why do they serve? Why did they join? And then we want to see what we can do to best serve them. There's no cookie cutter format. It's just what is going to fit the service member and the needs of that particular service member and their unit. This concludes my portion of the presentation. I will turn it back over to Ms. Alexandria.
Great. Thank you so much to all of our panelists for those really informative presentations and lots of questions here. So we encourage folks, we're going to do our best to answer as many as we can, but if there's still a question sitting with you that you may have liked to ask any of the panelists, please throw it in the Q&A panel that you'll see on the bottom of your screen. All right, so we do have a few questions to get started. And again, we welcome folks to please continue to submit them. We'll have the next 30 minutes or so to answer as many as we can. So our first question is for LaTanya and perhaps Staff Sergeant White as well. And the question asks, regarding increasing help-seeking behavior for alcohol concerns with Army Directive 2019-12, what steps has the National Guard Bureau taken to help combat the stigma to usher in this directive?
Staff Sergeant White here. Thanks, Alexandra. I'll go ahead and take part of that question, and then I'll let Kalandra kind of add in a piece on it. So when that directive first came out, what we did was we pushed out to the prevention staff when all the 54 and educated them on that. And then we kind of double tapped with our drug testing coordinators, teaching their unit prevention leaders, just to kind of spread awareness on that policy and that it exists and it's available for soldiers to use. Ms. Kalandra, did you want to add anything on that?
No, that was it. I think LaTanya did have some input on that one.
Yes, so I think we were talking about something similar before with the Georgia National Guard. What we did was we changed the soldier in crisis icon. And so we made it accessible for leaders and any service member that has a government laptop. They're able to go on there and see what services or what fits the description of a behavioral health crisis and substance use crisis. And then they are able to contact a provider, or they're able to, I'm usually on call, and my colleague here is on call as well. And they can call us and if they have any questions about anything. So that reduces the stigma among them that everybody has access to that icon, and they can use it at their ready.
Great, thank you both. Our next question, are there additional programs for soldiers not meeting the mandatory enrollment criteria in AR 600-85 due to previous alcohol or drug related incidents? And I wonder maybe if Staff Sergeant White and also again, LaTanya, if you may have thoughts on that.
Yeah, I'll go ahead and take that. So it's just really going to depend on the state and what the state has to offer and what community resources and partnerships that they have, and also up to the commander, because at the end of the day, it's a commander's program. So if the soldier doesn't meet mandatory enrollment criteria, but clearly substance use and and alcohol use that's not in line with using it appropriately, I should say, is a problem if it interrupts work and it interrupts drill. So I would say that it's completely up to the commander. The RCs and PCs within the field, they do an excellent job of, assisting those soldiers who may not need the treatment, but could absolutely benefit from the assistance from resources.
Also, I'd like to add in additionally to that, although the soldiers don't meet the criteria for an enrollment, we have providers that are in the National Service Database that we can still give that soldiers the information about the providers so they still can get the treatment and the services that they need.
Thank you both. Our next question asks, if someone gets separated for substance use from the National Guard or the reserves, do they get the same transition assistance as those who retire and receive an honorable discharge?
Absolutely, they do. Just because, they've made a mistake and they've, use substances or abuse them at all, not abuse them, but use them, in a manner that's not consistent with what our, values and regulation is, they're still absolutely entitled to the proper, discharge process and the resources when they're exiting, the military and going back into the civilian world.
And to add to that, Staff Sergeant White, as I pointed out, the separations are different. So if they are separated on a other than honorable discharge, then no, they would not receive any of those services. However, they can be connected to services within their community, as you pointed out. But any VA services, any additional retirement services, they unfortunately will not receive.
Thank you for that clarity. All right, our next question asks, excuse me, if testing positive, is it 30 days or 45 days that the soldier has to begin the program within the Guard?
Okay, I'm glad you asked because I know it can be a little confusing. So the regulatory requirement is that they notify the commander within 45 days, and the command has to notify the soldier. So it's kind of like a two-part process. So it can even leg on past that time if the commander can't get in touch with the soldier. So it's the 45 days that the commander has to get in touch with the soldier. The 30 days comes from, that's once the commander sits down with the soldier, counsels them and refers to them, then the soldier has 30 days to complete an assessment. So that's where the difference is. Thank you for asking that question so we could clarify that.
Right, and to add again with what Staff Sergeant White said, that 45 days, again, like I said previously, if the soldier tested positive in May, but the results didn't come back until June after they've already drilled, and they don't drill again till toward the end of July, you're looking at over 45 days just because of the status. So that 45 days can be prolonged a little bit because, again, we don't have access to the soldiers 365 like they do on active duty. We have them when they're there. And it could even be a little bit farther in the event the soldier was asked to be excused from that drill because there was a family emergency. Then they don't come back until September. And then maybe at the end of September, budget is all, jacked up. They may not drill in September. So it could go to October, or the soldier could have been transferred to another unit. So you have to send the paperwork from that unit to another unit. So there are a lot of reasons why they may not meet that time.
Great, thank you. Our next question is around on a similar topic. Would refusal or lack of treatment lead to discharge?
Yes and no. So it's going to be case by case. The regulation, you're laughing because you know what I mean, Miss Latanya. So the regulation, the verbiage in there says failure to rehabilitate would mean separation actions, but it could be so many different reasons why, of course, case by case. So if the soldier flat out refuses treatment, it's going to be up to the commander to decide what they want to do, but lack of treatment could also mean they just don't have the financial means to pay for it. So it would be case by case. Ms. Latanya, did you have anything else to add on that part?
That question is always funny because keep in mind, as it was pointed out, it's a commander-driven program, right? And so you may have a commander that really cares about well, hopefully all of them care about their service members, their soldiers, but there may be a soldier that is really working hard. However, they have these struggles, so they're going to work with them. But when it comes to a liability, we have to have some tough conversations with the commanders. Like, look at the big picture here. This person isn't compliant, isn't going to treatment, isn't doing anything that we're asking of them. Is that really becoming of a soldier? So after we have that tough conversation, commander still drives on with the decision that they're going to make. However, we've definitely noted that we're making recommendations that they get treatment on the outside of the military.
Mm-hmm. And I might add to that also, the soldiers are all aware of the zero tolerance, but it's hard for them to recognize that it's also a case by case basis. So I've had soldiers that I've spoken with and I was like, okay, so why did you go AWOL? Well, zero tolerance, they're going to kick me out, so it's about, they'll hold on to one thing and it's hard for them to dump that and accept something else. They're like, oh no, it's zero policy. That's been drilled in my head since basic training. So sometimes just talking to them makes a difference. Well, yes, the military regulation says, no illicit drugs, or don't take prescriptions that don't belong to you, or they've exceeded that. What the regulation says, but the adjutant general is the final approving authority, and it is a case by case basis. So there have been many of soldiers where we've spoken to and we've told them that, and they were like, oh, well, yes, I want to get treatment. I want to continue with that one. So that's just one of the scenarios we've had.
Great, thank you all. Our next question asks, are family members able to obtain services such as some of the free mental health counseling that's been discussed here?
Yes, family members, we have a family support branch. So they're able to obtain services through the family support branch. That's their primary role, is to support the family members. A lot of times when there's a behavioral health issue, the family members or the family support services branch will reach out to behavioral health to see what additional resources are available for those service members. But definitely we provide services to the families as well and connect them to the same community resources as we would a service member.
Thank you. A few questions around access and coverage. Someone else has asked, does Military OneSource provide alcohol and drug assessments? And also, do they provide drug and alcohol treatment?
From my experience, and I think Military OneSource is wonderful, and I think it's a wonderful resource for our service members, but I think one of their disqualifiers is a substance use disorder.
Thank you. This question is for Staff Sergeant White, but I think it's a clarifying question to something you had shared earlier about in your presentation. And the question asks, did you say that if the service member self-refers, they do not have to follow the treatment plan?
So if they self-refer for drugs, then they absolutely do. So the voluntary alcohol policy, if they self-refer and use that, they don't have to. So say they started a program and they feel like maybe they don't need to stay in the program and they're good to, disenroll, they can do that, but that's only for alcohol. And I talked about earlier the failure to rehabilitate. So a soldier who uses their limited use policy and they decide to back out, the commander can view that as failure to rehabilitate.
Thank you. As a similar follow-up, if a service member tests positive for illicit substances, are they still eligible for deployment and or orders? No. Okay, I'm seeing some head shaking.
That's a good question. For deployment, so there is a part in the regulation that states, if the commander feels like they want to let the soldier and suspend all actions until after a mobilization, they can choose to do that. Typically within our states, they will not put a soldier on orders if they are drug positive, because along with being a drug positive, per the regulation, the soldier has to be flagged. So what flagging action means, no favorable action, no promotions, and then ADOS orders and going on orders is kind of like a favorable action, if it makes sense. So typically they will not do that. And that includes state active duty as well. So for state missions.
Right. And in addition to that, like she was saying, they're not able to put on those orders for 30 plus days because not only is there a flag, but their clearances are suspended and things like that. So they aren't able to do that. But we have had instances where, again, the soldiers' part in the mission was somewhat vital. So they were able to suspend that. The soldier deployed. And when they came back from the deployment, after they had their 90-day refrat, or their refrat period, when they came back to drill, then the process started.
Great, thank you. A number of questions following, again, the similar topic. What happens to those soldiers who are not on orders and do not have insurance, who need substance use treatment? Any thoughts from folks on that?
When we have partners with some of the some facilities in our communities, there are some that will give the 12 free treatments, but there are also the ones that will let the soldiers use their drill check because that's the only income they may have, and they can use that when they're trying to determine their sliding scale payments.
I would just like to add to that, Ms. Ferguson, and that there again comes the creativity and the partnerships within the community to provide those services. Like the community service board, we will send those service members over there. The issue comes in if they want to, because they're with the regular population at your community service board. And so we'll screen them out. We'll see if they've ever deployed. If they've had a deployment in the past, then they're eligible for services through the VA or through your vet centers. So we will try to leverage those community supports. We will also utilize some of the free services or those partnerships that we have built with Centerstone Counseling. So we will leverage that. And then also the third and last piece of that is accessing those services through your community service boards or their local community service boards.
Thank you. Our next question asks, what can be done before soldiers get down this road? Essentially, are there any sort of earlier actions or interventions or opportunities to provide support before it gets to sort of crisis mode? So I see some head shaking of folks who might want to weigh in there. Yeah.
Oh, wow. So absolutely. So for us, my team, we are some of the primary trainers, and we go out and we teach substance abuse prevention. So we're on the prevention mode. We talk to them about the policies and the regulations. We talk to them about the effects alcohol and drugs has on your body. We talk to them about their role as a soldier and what they're required to do. So we do that as prevention, but we also do conduct the unit risk inventory, which is an anonymous survey that the soldiers fill out at the unit. And it asks the questions about, are you drinking and driving? It asks a lot of questions about, even if you've had thoughts of suicide, or you've attempted suicide, if you're having financial difficulties, so we also have the unit risk inventory. And after that's been processed, then that'll let us know. It won't tell us specifically that, Sergeant White or Sergeant Ferguson said, yes, they have drug or alcohol issues, but it would let them know that someone within your ranks has that. So we can go out and do specific, it's called the targeted training. So that's what my team does.
And I'm going to add to that. I hate operating in crisis mode, honestly. So I love the fact that we do a lot of prevention, a lot of preventive services. We try to implement those, as Ms. Ferguson pointed out, doing the unit risk assessment. And I would say that whenever we have, it's unfortunate, but whenever we have a suicide or someone that died by suicide, we go back and we look at that URI. And we look at that unit risk inventory, and we see what was going on with that particular unit. We look to see if there was substance use within that unit. And as a team, we go to that unit and provide training. So in addition to the TIMS debriefing, which is the traumatic event management debriefing, we would also provide some prevention training. So we want to make sure that, yeah, we had this crisis to occur, but what can we do to prevent future crises from occurring?
Thank you, very helpful. We have a question asking, are all these policies similar in each state regarding the Guard? And the question asks around if Michigan's National Guard would follow the same treatment modalities, but assuming there may be folks in other states with the same question.
But we all follow the regulations, the PPOMs, but there may be some state policies that are a little bit different. So we all follow the major regulation, but sometimes you may do it a little differently. It's kind of like you can get there by plane, train, or automobile as long as you get there. So each state does things a little bit differently, but we all follow the basic regulations and the policies that are in place, but we may just have some things different that we do. So each state is going to be different. However, all the states, territories, and the district, the risk reduction coordinators, we meet, the different regions. We have our bi-weekly meetings and we talk about best policies. So Hawaii may be doing something differently from Georgia. However, they're still providing services to the soldier. They're just going about it a different way.
Thank you. All right, our next question asks, with Chapter 3 for command direct to psychological health, can they command direct for M days or only on orders and ARG?
Everyone.
Everyone.
Everyone can have a Chapter 3 physical. We start with the tiers, so those service members who probably had a deployment, and that regulation is just, evolving. But if they've had a deployment, we definitely want to go on and do a fit for duty evaluation. However, if I evaluate a service member and I feel that this is just not the right environment, or that there is something else going on, then I may communicate with the commander about conducting or sending that service member for a fit for duty evaluation. So it doesn't matter if they're in-day or AGR, it's the same policies apply.
Thank you. All right, and someone's shared a question around our veterans who may be experiencing homelessness, complications from substance use concerns. Is there anywhere that folks can go to get free services in their state? And if so, can anyone speak to how people may be able to track down how to help those folks get connected to some care?
Okay, so here in Georgia, we have the Georgia Department of Veteran Services. So a number of our veterans, and if they're true veterans, because there's a difference with Guards members, people get it confused because they're in the Guard that they assume that they are off. They're actually veterans, which they are in our eyes. They are veterans. However, in the eyes of the VA, they are not considered veterans unless they've had 2 years of active duty or they've had a deployment. So when we do an assessment of a service member, we have service members that come in and they are homeless, unfortunately. And so we try to utilize those community resources as well as the Georgia Department of Veteran Services to provide supports for them. Once we identify if they're veteran status or if they're National Guard or Traditional Guards member. Traditional Guards member, as we pointed out earlier, they're unable to access some of those resources through the VA. However, they can access some of the community supports that are available for anyone that has put the uniform on.
Thank you. Next, we have a question asking, are there any special considerations given to soldiers who were wounded or injured on duty and may have become addicted to painkillers or other addictive medications?
So I would say, I'm just coming from a national perspective and from the drug deterrent side, if the soldier was positive for those, at the end of the day, it's up to commander on what they want to do. They still have to execute the regulatory requirements, assessment, flagging action. But, of course, every soldier is different, case by case, but follow what the regulation and policy says. So I am sure that if that was a situation with a soldier, the commander would absolutely consider that, and then also consider that when providing resources, someone who can assist with not only the substance abuse related part, but also the other factors that they're dealing with.
Thank you. Someone has asked, is this the same for the Army Reserves? And so how do reservists get access to behavioral health services? Are there any distinctions or anything extra to clarify?
From my understanding, the reserves they currently have a psychological health program. And so there's one of me, Director of Psychological Health, Psychological Health Coordinators. We're across the state, and every branch of service has those resources as well.
Thank you. And so we encourage folks to keep the questions coming. We're doing our best to get to as many as we can. So please continue to enter them in the chat and we appreciate it. Next question asks, are the DISTech contractors trained to offer the ADAPT course?
So currently right now, the national contract does not have that outlined in there. We have been, exploring that as it is a requirement, as you stated, but that is something that we currently do not have, and we'll go ahead and take that back to our leadership and to kind of revisit that.
Thank you. All right, our next question asks, what is the average cost of substance use treatment? Something that we may not talk about quite as much, but.
Okay. Here in Georgia, some of the average costs for an assessment can go from $75 to $125. And for any intervention education, any sessions that they may need after that, some of them range from $50 to $75 or $100. So that's kind of like the average cost that we see in Georgia.
And that's for your outpatient, but your inpatient can go up to the thousands. And sometimes it just depends on the service member and how invested in their military career they are too. Sometimes they have the money to pay for the services because wearing the uniform and being in the military means a lot to them, and they want to do whatever they have to and whatever they can to make sure that they remain in. So they figure out a way, but it can run into the thousands for your inpatient treatment.
Thank you. A follow-up question asks, if a soldier is in treatment, will that affect his or her career? And what might that look like for people who might have that as a concern?
So you all asked a question earlier about reducing the stigma. And so the goal is to reduce the stigma, and we want people to ask for help. And so while they're in treatment, then we're going to take care of them. No soldier left behind. We're going to continue to provide services for them, make sure that we're communicating with the treatment provider. Now, what we will do is put them on a temporary profile for substance use disorder. And that just covers them. It covers the unit. It protects them. They can't carry a weapon is the most that we would do during that time. But they will be placed on a 30-day profile, and we will assist them as we would do anyone else with a medical condition.
Thank you. Next question asks, is the same crisis line 1-800-TALK? Would that be the same used for the National Guard and the Reserves? Is it the best place for people to start if they're looking for a phone number to call?
For Georgia, we have our own crisis line. So we have partnered with Georgia Department of Developmental Disabilities. And also the VA crisis line. So we have that as additional resources, but we have 2 providers that are on call to answer those calls if we receive them.
And I would say that crisis line would be good. Of course, any crisis line is good when they're in need of help.
Thank you. This next question asks a little bit about one of the case studies, and I wonder if panelists would mind if I flip back a few slides for this. It was the example with Sergeant Snoopy. Let me find him for her. It's a him. Here we are. In this case study, could Sergeant Snoopy go to the VA since he did deploy under Title 10?
Yes, he is able to access services through the VA. He had a deployment, and he's been on active duty for about 2 years. However, he is able to get treatment fast. We can do both. Like I said, there's no cookie cutter way of doing it, but he was closer to a military treatment facility, so we were able to get services through the military treatment facility. But as we get ready to transition him, we will also connect him with the VA.
Great, thank you. All right, next question asks, do most interventions address moral injury, which can be part of SUD, substance use disorder?
Unfortunately, what we're learning, those who are receiving treatment in residential settings, they are addressing moral injury. However, when we're in crisis mode, we're trying to navigate resources at that point. But once they get into a treatment facility, or if they're in long-term care, when I review the treatment notes, I'm seeing that they are addressing moral injury. And a number of the case presentations, that was one of the issues. I think 2 of those, that was one of the issues.
Thank you. An additional question was asked around what happens when individuals test positive and have weapons? Is there a safe place or a place for safe storage, or how might that conversation go to just help ensure safety?
So there's actually currently our office, what we do, and it's a regulatory requirement. So all soldiers identified with a positive urinalysis, an illicit one, their names are submitted into the National Instant Criminal Check System, so NICS with the FBI, and they are not able to hold weapons for a whole year. So their names are inputted for the year from the date that their positive was certified by the lab or the date that their prescription positive was adjudicated as an illegitimate positive. The responsibility of the commanders is to counsel the soldiers and to advise the soldiers that they need to divest any firearms or ammo. But we are not, it is not up to the commander to give them a safe place to store their weapon. But it is up to the commander to advise them of why they need to, divest the firearm and what the consequences of it, not divesting it will be, which would be a felony offense, potential felony offense. But is the onus of the soldier. So no, we do not provide a safe spot for it, but absolutely as soldier to soldier or commander to soldier to, ask them, like, where do you have to put this weapon? How can I help you? Do you have family? And then advise them, where they can't put it. You can't pass it to your wife who lives in the same house as you because it's still under your roof. So I hope that answers your question.
Great, thank you. We're coming close to the top of the hour, so perhaps we'll end with one final question, and we invite our panelists to share any closing thoughts, either in reflection to this final question or on the presentation overall. But who is eligible for VA services?
I guess I'll take it. So those service members who have deployed or who have spent 24 months on active duty are eligible, or those with a military sexual trauma or who have been injured on active duty at any point, they're eligible for those services. They have a service-connected diagnosis.
Great, thank you. Any closing thoughts from the rest of our panelists?
I'd like to say that we work so hard in our communities because a lot of our National Guard soldiers, they get an NGB Form 22, which is their discharge documents. And that may not necessarily give them access to the VA. So with our traditional M-Day soldiers, we work so hard to create these partnerships within our community so that we can give them the continuity of care that they deserve. But again, my office, our goal is to improve the lives of soldiers. And that means if their spouse or their child needs something, we can give them information or we can transfer them to our military family services branch. So it is, we want to improve their lives on every aspect.
Great, well, thank you. And thank you all very much. Sorry, Staff Sergeant White, did you have a final thought? I saw you unmute.
I did have a final thought. Yeah, I just want to thank everyone. And I do want to say, just coming from a national perspective, and, we really try to help our soldiers in every way we can. My division, it's full of, suicide prevention we have in my division, resiliency, all those things are preventative measures, with resiliency and kind of tackling it on, our warrior and resilience and fitness division, right? So, we try to go from different avenues and prevention, it's the number one thing. We can only react when it comes to drug positives and soldiers coming for limited use, but it's the prevention effort is what really is going to kind of help us. So thank you all very much.
Well, thank you. We'd like to extend a warm thank you to all of our panelists today for sharing their insights and their expertise on this topic. We want to thank you all also for attending today's webinar, Best Practices and Systems of Support, Addressing Substance Use Among Our National Guard and Reserve. Once you leave today's webinar, you'll be redirected to a survey on the presentation, and we'd appreciate if you could take a moment to complete that and provide your feedback. The recording of today's session will also be available on the National Council's webinar archive page within the next 48 hours. And on behalf of the National Council for Mental Wellbeing, Policy Research Associates, and SAMHSA's SMVF TA Center, we'd all like to thank you for joining us today, and please enjoy the rest of your day. Take care. Bye, everyone.